Good morning. Thank you very much for this opportunity. My name is Domenico Tamburrino, and I will talk about the natural history of a large cohort of patients with a low-risk branched duct IPMN. The authors have nothing to disclose. We know that there is a high prevalence of pancreatic cyst in the general population, which is around 10%. And we also know that the overall malignancy is very low. However, several guidelines have been published in the last 10 years regarding the management of IPMN. The aim of this study was to describe the natural history of a large cohort of patients with low-risk branched duct IPMN in order to identify risk factors for the development of Wilson feature and high-risk stigmata. And as a secondary outcome, we try to define a subgroup of patients with low or no risk of progression over time. This is a Pancreas 2000 group, and we performed this retrospective analysis of patients with a presumed diagnosis of branched duct IPMN without Wilson feature between January 2006 and December 2015, with a minimum follow-up of 24 months, and the malignancy was defined as high-grade dysplasia or invasive carcinoma. The definition of Wilson feature and high-risk stigmata were based on the international guidelines published in 2012. We started from more than 1,000 patients, and at the end, 837 patients were enrolled in the study with a median age of 66 years old. The overall incidence of Wilson feature and high-risk stigmata was 20%. You can see here at 5 and 10 years the overall incidence of Wilson feature and high-risk stigma. We have also seen that the overall incidence of malignancy was about 2%, and 4% of patients were operated with Wilson feature or high-risk stigma. In this study, we have seen that there are two different orientation in the management of the follow-up, which is one more endoscopy oriented in center 5, 6, 7, and 8, and one more radiology oriented in center 1, 2, 3, and 4. However, if we look at the multivariable analysis of factors associated with the development of Wilson feature and high-risk stigmata, we can see that the endoscopy-oriented center, male gender, as well as the bursum size and the sites of the cyst are associated with an high risk of Wilson feature and high-risk stigmata development. We also performed a subgroup analysis in patients with the main pancreatic duct less than 3 millimeters, with a cyst size less than 15 millimeters, and without any symptoms at baseline. And in this slide, you can see that the 5-year cumulative incidence of Wilson feature and high-risk stigmata is less than 10%, and the 10-year cumulative incidence is less than 20%, which is considerably lower if we compare with the entire cohort of patients. So the conclusions: in the non-operative management for this patient is safe. The overall rate of Wilson feature and high-risk stigmata is about 20%, with an overall rate of malignancy of 2%. We can try to discontinue the follow-up in a subgroup of patients with a low risk of progression, considering also the life expectancy. And we also need to consider different follow-up modality. This is a provocative question. Probably the US is superior to over MRI and CT scan. I would like to thank all my colleagues, and I would like also to thank you for your attention.